Thank you. Thank you very much. It's my pleasure to open this session on the global epidemic of hypertension. This is such an important problem. We say in the title, the avoidable $4 trillion toll. And in fact, when you look across the entire planet and all of the people with hypertension who are not receiving appropriate treatment or not receiving appropriate care, about $4 trillion is what it is costing us, which is just an amazing amount of unavoidable costs every year. And even more so when you recognize that in so many parts of the world, the consequences of hypertension are so difficult to care for. We know that hypertension is a risk factor for stroke. It's a risk factor for heart attacks. We know that those are two of the most important causes of morbidity and mortality, even in the United States. We also know that even in the United States, that only a little more than 50% of people with hypertension are treated, and those are those about whom the hypertension has been recognized. And so that while I think it's right and appropriate for us to talk about this as a global epidemic and what we can do globally, that we also need to keep into perspective that we haven't done the job that we need to do in this country as well. So it's my pleasure to turn to our panel and ask you each to introduce yourselves very briefly, so to give the audience a little bit of a sense of, not only who you are and what you do, but your interest in this issue and hypertension control, perhaps starting on this end.
Sure, thank you very much. So I'm Kenneth Connell, and I am the Dean of the Medical School in Barbados, the Faculty of Medical Sciences, the Cave Hill campus. I'm also the Principal Investigator on the CDC's and PAHO-sponsored Standardized Hypertension Treatment Project. And this is my second time here in what I'm told is warm DC, but leaving an island where the lowest temperature we have is about 21 degrees Celsius. I'm still looking for the warmth. So the SHTP model is one that looks at health system strengthening, and it's been introduced in Barbados just over 2 years. We're just at the 2-year mark, and it has caused a tsunami of change throughout the island, and I hope to share some of the experiences with you.
I'm Nieca Goldberg. I'm a cardiologist and medical director of the Joan Tisch Center for Women's Health at the NYU Langone Medical Center in New York City. As a cardiologist, I've focused my career on cardiovascular disease in women and worked on the early development of the Go Red for Women campaign. Happy to say that this is the first year we can say that the death rate due to cardiovascular disease in the United States has decreased in women, but unfortunately we've only missed we've gotten that based on reducing risk of heart attack and stroke in women who are over 50, and the heart attack rate in women between the ages of 45 and 54 has been increasing in our country, and one of the major risk factors for that is hypertension.
Thank you. I'm Steve Kopetski, preventive cardiologist at Mayo Clinic in Rochester, Minnesota. I started out my career in the coronary care unit in the cath lab doing angiograms and stents. And about 10 years ago, I migrated into prevention because I got tired of seeing the same patients over and over and over again, which we tend to do in cardiology. And it's become very clear in my tenure as the president of the American Society for Preventive Cardiology how much we can prevent heart disease, and hypertension is a big, big part of that with lifestyle and the key elements of lifestyle and the things we all need to do, but unfortunately very few of us are doing.
Good afternoon. I'm Paul Welton. I'm Chwan, Dean, Chair of Global Public Health. I started as a nephrologist and trained in clinical epi, and then spent a lot of my time as Dean, Chancellor, President, CEO. But I always have been interested in blood pressure as a fundamental risk factor, and been involved in a lot of the big trials, chaired a lot of the big ones, Sprint, AllHat, and so on. A lot of international work, and now I'm chairing the 2016 ACC and AHA blood pressure guidelines for the U.S., so it's a real pleasure to be with the panel.
Paul, maybe it would be good to start with you to just give the audience a little bit of a feel for, when we talk about hypertension, what do we really mean by that? Right. And your sense of how we should be going about identifying people that have it and taking care of them.
Well, let's go to basics and say the body doesn't understand the term hypertension. It's a man-made tool. It's useful as a practical entity for deciding what to do, but the body understands blood pressure. So high blood pressure, really, we see an increasing risk throughout the distribution, from the lowest to the highest. And if you use that approach and say increasing risk, that's what Tom was talking about at lunchtime. That's where you see the really big impact, more than tobacco in terms of risk. And then we've arbitrarily put some cut points for hypertension. When I started, we used to say above 160 systolic, then it went to 140. I'm pretty confident it'll go lower than that, because if you go from 130 to 140, you've more than doubled your mortality risk. So if we take hypertension as we currently define it, 140, 90, or use of meds, in 2000 we did a global estimate. How many people were there? It's about 26% of the world's population, about 1 billion people, about 2/3 in economically developing countries. And fast forward to this year where we've updated that, it's now at least 1.4, probably closer to 1.8 billion people. So enormously big problem, whether you look at hypertension per se or you look at blood pressure overall. And we have a number of strategies that we'll talk about for how you treat hypertension and, of course, preferably how you would prevent hypertension. And the challenge is to implement those. We know things that work well, and we don't do so well. We know things that work, but they're really hard to implement. So I hope we'll have a good chance to chat about some of those issues.
Okay. So I'm getting the sense from what Paul is saying that we have these arbitrary cutoffs above which we say it's hypertension, below which we wouldn't call it that, but it might be better for us to have lower blood pressure at all kinds of different levels. So I'm wondering, Steve, if you could help us down the path of the evidence that we have. What are the things that we can do that help us to lower our blood pressure? Whether our blood pressure is classified as high, or I realize there's a borderline category, but what does the evidence show? What can we do?
Yeah, the lifestyle is so important for blood pressure in that if you put more fluid in the pipe, the pressure goes up. So that's food, that's salt. And we're all eating, as you heard this morning, about 3,300 milligrams of sodium a day. It should be maybe half that. The more you eat, the higher your pressure, the more the fluid in your system. So the fruits and vegetables will lower blood pressure separate from that. Even if you eat an isonatremic diet, meaning the same amount of salt, eating fruits and vegetables will lower blood pressure. Vigorous exercise, interval exercise, going hard for a minute or two, no longer, 4 or 5 days a week for maybe 20, 30 minutes, will lower blood pressure by making the pipes bigger. Things like smoking, which, fortunately the numbers are going down, but that makes the blood vessels smaller. And then finally, weight. Weight is one of these problems it's just gotten to be a huge problem, obviously, in that every pound of weight you gain as an adult is an extra 5 miles of blood vessels your heart has to pump through. So your heart pumps 100,000 times a day. You do the math. 1 pound, an extra 500,000 miles. 2 pounds, 1,000,000 miles extra. So the blood pressure goes up with weight. And it can go down as you lose weight, which none of us are doing a very good job, unfortunately, doing. In fact, the 4 things we should all do: have an ideal weight of 25 BMI, certainly less than 30, don't smoke, eat 5 fruits or vegetables a day, and be vigorously active for 150 minutes a week. What percentage of American adults do those 4? About 3%.
So I'm trying in my head to do that math, and I can't quite make it work with the miles of blood vessels, but I'm struck by the idea that those 4 things could be effective. And is it really true is that true for everyone? Or is it that have we been able to actually do, I guess, the research that would say, yes, if you could do those 4 things, you basically wouldn't have high blood pressure?
Yeah, I mean, there's obviously causes for blood pressure that are genetic that wouldn't be in this category, but most of the blood pressure is lifestyle. probably half of it, at least half of it, depending on the population, but at least half of it could be normalized with lifestyle.
You know, Virch made the observation, he was a great pathologist, he made the observation in the 1800s that epidemics are reflections of culture, and they are. And that's true for our cardiovascular epidemics. And we know from a lot of trials of behavior change, a number of which I was involved in, that we can certainly prevent hypertension. We can certainly treat hypertension with non-drug approaches. The challenge is changing behavior and maintaining that change. That's very difficult, and that's where we struggle. We do great for the first 6 to 9 months, but it's difficult after that. I think in terms of blood pressure, one area in a country like the U.S. Where it's going to be difficult, but we could have a lot of huge impact, is around encouraging, and I'll use that in a very diplomatic term, manufacturers to not add so much sodium. So 80% of the sodium on average that we eat is added in our foods. It's hidden. And it leaches out the potassium.
No,
and if we could gradually change that, that's the one area where people wouldn't have to do anything, and they would derive huge benefit.
Well, that's
Nieca,
one of the points of the most popular diet probably in America that we use is something called the DASH diet that was supported by the NIH. And that studied a diet rich in fruits and vegetables and low-fat dairy products and what was referred to earlier. And the DASH diet can lower blood pressure, the systolic or the top number, anywhere from 8 to 14 millimeters of mercury. It's really interesting that the initial trial was done on 459 patients without changing the salt. And then they did another trial where they lowered the salt and got additional blood pressure lowering. And what's really nice is, you know, all day long you've been hearing about big data and electronic health records. And one common thing that we do at NYU is we use the EPIC medical record system, and you can actually type DASH in. So you could have doctors type in DASH and have a person leave the office with an abridged version of the DASH diet. So it's very important to realize in order to change behavior, there has to be an investment. If you go to the average person with hypertension and you tell them you have to lose weight, you have to exercise, you have to change your diet, you're going to lose them. So it's important to start with one thing and then go from there when you're just looking and working with an individual. But when you're working to lower global hypertension, particularly in women, you have to look at the whole issue of hypertension in women. First of all, the prevalence of hypertension increases as women age, and it's estimated that 75% of women over the age of 60 have hypertension. Yet younger women do have hypertension. The incidence is much lower. And we have to look at these younger women. And the reason why I bring it up is because in younger women, one of the most preventable ways and work on lowering blood pressure is in obese women. Because younger women with obesity, weight loss is much more successful than in postmenopausal women in terms of lowering blood pressure. But there are other times when women have high blood pressure, such as hypertension of pregnancy and preeclampsia. And although preeclampsia only happens in about 8% of pregnancies, I think a very important fact is those women are at risk of developing hypertension in later life. But 5 to 10 years after that delivery, in the woman who is preeclamptic, she is at increased risk for having a heart attack or stroke. So you're talking about a woman who has a 5 or 10-year-old child who may have a heart attack. And so it's also important to look at the behavior of women and how they take care of their health. They regularly go to the doctor when they're pregnant, and then they're sort of lost to the system until they reach perimenopause. And we have to find a way to improve their health throughout their life cycle.
So, Nieca, when I was in medical training, there was very little in the education about either hypertension in women, or for that matter,
Heart disease.
stroke a little bit with contraception, with hormonal replacement therapy. They would talk about stroke risk with those things, right?
Right.
But, you know, I'm not sure whether that has changed a lot in the medical professionals, certainly those trained in my cohort. You know, to what extent are they learning to recognize this, but also the young women who are coming in for care. They may be going to their OB-GYN. A lot of women do go in for a physical, you know, for that. But are they getting their blood pressure checked?
Well,
and are they aware of this?
Well, I think more women are aware, and the good news is women's health, which includes women and cardiovascular disease, is part of the medical curriculum in medical schools. It's a required part of the curriculum for medical students. And just take as an example, at the NYU Langone Health Center, throughout the system of ambulatory practices and hospitals, blood pressure is taken anytime a person comes in for a procedure or office visit. So at the Women's Center, everyone's blood pressure gets taken as an example. And I actually have a dashboard, and I can see how blood pressure is being treated at the Women's Center. So I think dashboards are very important in health systems. And you need to work with populations, and we have a very robust population health department, and we have to work with populations of people. So at the Women's Center, those people already have access to the system. So it's important to understand that it's not only about eating a healthy diet and behavioral change, it's also how those women can get their blood pressure checked. And having programs where blood pressures can be checked in pharmacies, in barbershops, in supermarkets, having health fairs, but doing something with the data. And also the use of technology. And as an example, off of hypertension, I actually had a patient who came in who didn't get to the hospital in time recently to catch their arrhythmia, but she caught it on her phone.
Her smartphone, yeah.
It's interesting.
So she showed it to me.
So Ken, I'd like to turn to Ken for a moment, because I'd like to hear a little bit more about this pilot study that you've been involved with in Barbados.
Sure.
I've heard great things about it, but I can't say I really completely understand how it works and the potential to be able to adapt that approach across the world
Sure,
and other countries.
Yeah.
If you could tell us a little bit about it.
Good. So Barbados, in our 50th year of independence, we have a lot to be proud of. So we have Rihanna, and we also have a lot not to be proud of. That was my plug for tourism. So, and the one thing we don't have to be proud of is we are known as the amputation capital of the Caribbean and possibly the world. We have a high amputation rate. Our rates of stroke and cardiovascular disease are going up. The amount of added salt. I mean, if any of you have visited Barbados, you'd know most of the meals are high carbohydrate.
Well, and for the non-medical people in the room, amputations.
Removal of limbs. So removal of the limb because of infection due to poor healing from diabetes. And the other thing we have is a drug budget that's being stretched by the NCDs. And so 60% of our drug budget is being spent on the care of hypertension. Yet our control rates are less than 30%. And so governments, the university, CDC, PAHO, and all the important stakeholders have rightly said, well, something's wrong. You guys have got 35 drugs on your formulary, and we do. You're free to choose any of them because they're free, and the doctors in public practice do, but yet our control rates are so low. And so we thought that we would address a systems approach to change, and that's essentially what the Standardized Hypertension Treatment Project advocates. So the use of core, cheap, evidence-based drugs, which, by the way, the #1 prescribed drug in the public sector in Barbados is the most expensive ARB available. And though medics would say that they're not being influenced by the drug companies and all of the advertisements, they are. They're all over the clinics, and it just happens to be that's the #1 drug. The second thing is, how do you get doctors to follow a protocol? And this is something that even as an academic, I struggle to get students to follow protocol even for exams. And the ACC, AHA protocols are there, and doctors who are part of these colleges would say, well, yeah, we're following the protocol, but they aren't. They're really just following whatever drug is out there, or whichever drug company is just passed through the office. So how do you get them to follow the protocol? And the key to that was actually competition and monitoring and performance metrics. We're more likely to follow things if there's a carrot and if there's a stick as well. And the carrot is obviously the control rates, and obviously the stick, someone's looking over your shoulder, say, well, why did you choose valsartan as your first-line drug? And interestingly, the person that's doing that now is not necessarily the healthcare provider at all. It's amazing. You wouldn't believe who that person is. It's the patient sitting in the consultation room, looking at the protocol that's stuck up behind their doctor's head and saying, well, why aren't you using a diuretic as the first-line drug? According to your protocol, I should be on a diuretic. It's kind of hard as a healthcare professional then to justify it. Well, it's because the valsartan rep was in here before you came. So it's a challenge. And so it's created change. And not just change in practicing doctors, but also in medical schools, we are teaching more protocol-based, systems-based approaches to the management of the NCDs.
So I'm hearing about a number of possible approaches ranging from across society getting the salt out of the food. And boy, I mean, there are some foods that have more salt than you're supposed to eat in one day in one serving of food, right? So it's kind of crazy.
That's our national dish.
How much salt that is. So that's an issue in Barbados. But a number of lifestyle interventions, protocols, use of protocols, but also this monitoring that you're doing. And I'm just wondering, you know, I kind of sense that some of you were responding, but do you have reactions to that? Does this seem like?
You know, I wanted to say one thing. Our problem is pretty common around the world. So we have about 30 isolated societies that do all the things that Steve talked about, and they don't get any high blood pressure. So we know that biologically, you don't have to get high blood pressure as you get older. But most societies, including ours, that's the norm. It's very common.
Could you name like where there might be there?
I've studied with colleagues in detail a group called the E-People. They're isolated societies. They don't eat much sodium. They exercise a lot. They don't know cigarettes. They've never seen them. So they do all the things that we would like them to do. But the common problem worldwide is similar to what we have. Blood pressure goes up with increasing age because of all the personal environmental factors, and we get the complications. How you address that has to be very different by country. So if you're in a developed country like the U.S., many of the European countries, we have very well-developed systems of care, and people come in contact with those systems a lot, anywhere from 4 to 7 times a year. So we're measuring blood pressure, and we can put into place systems approaches with the use of the right providers, certainly pharmacists, nurses, people other than physicians who have time and effort to put in. We can use those electronic systems as active feedback. We can do a lot of things. If, on the other hand, you're in where most of the people in the world live, in sub-Saharan Africa, in many parts of Asia, people do not come in contact with the system. Sodium, unlike the U.S., where we said it's all added in foods, or 80% of it, it's added during the preparation of food. So the solutions have to be customized depending on what society you're in, but there are solutions for each society.
Do you realize that here in the United States, if you ask people to cut back on processed foods, you would really greatly reduce their sodium intake and drive them to eating a healthier diet? You know,
exactly.
That's really.
Or if we could change the way processed foods are prepared.
Right.
That's very interesting you say that. There's actually one of the major food groups in the world, the chief medical officer tried to reduce the sodium. So it's 1 calorie, 1 milligram of sodium. You eat a 2,000 calorie diet, you get 2,000 milligrams of sodium. He said that the the buyers walked away from it. They would pass it over and buy the next stuff that had more sodium in it.
Sure.
That's very interesting.
If there's a choice. I think that's part of how food is marketed,
It-
right?
it's
If
sort
there's a
of
choice, people will
custom.
choose the sodium-laden food,
It's
right?
what we're used to. When we do sodium reduction trials, at the end of that sodium reduction
Go
trial,
out and eat salt.
people find salty foods very
really?
unpalatable, very unpleasant. They
Yeah.
do not want them. But most people in our society are accustomed to eating a lot of sodium, and you have to, if you're going to reduce it, it has to be done slowly and gradually, but it can be done.
I mean, I've probably spent a lot of time talking about what's the right amount of sodium, but I wanted to switch to what's the right amount of hypertension control. I think you heard Tom
Right.
Frieden talk about that a little bit on stage, and you heard me say in the United States about half of those identified with hypertension, according to the federal government, have it under control. I don't think that's true in all populations. But what should be the target? I mean, have you thought about that in Barbados? I'll just go down the line with that.
Right. So we're currently working on a target of 100%, which is impossible.
A 100% target.
Yeah, I mean, that's what we all want in the healthcare setting.
It's aspirational.
It's aspirational. Realistically, we're probably going to get up to about 70%.
70.
Yeah. But this is going to be with time and changes, major changes. I just wanted to touch on what was mentioned previously about how do you get lifestyle changes occurring. One way of doing that is through legislation. Our current government has been quite unpopular because they've introduced a sweet tax. So foods that are high, that are sweet, are taxed heavily. We'll see what happens in the next general election, but it's heavily taxed. So the same tax that's on cigarettes because of the health impact is also on sweet foods. And we on the NCD Commission have engaged all of the manufacturers and a lot of our major processing plants to reduce their sodium by 25% every year. I remember being a PhD student at King's College, and at the bottom of Guy's hospital is a McDonald's. It's not the best thing for a hospital, but if you wanted to get salt, you could easily walk up to the condiment section and you get your salt. And what they did is they removed salt next to the ketchup and all the other stuff, and you had to go to the cashier. And that was a major barrier. I mean, I did not want to get up, having paid for a meal, to go back to the cashier to get salt. So there's simple barriers, removing salt from off of the tables and stuff. We had some salt on our table here today. So things like that are major factors that I think can influence.
What do you think the target? Do you have a target in your
In
clinical
terms of
setting?
blood pressure, or
In terms of the
blood pressure
percentage
control,
of those who are identified, that are controlled.
we would like at least 80% of the patients controlled with their hypertension, and I'm happy to say that at the Women's Center we're very close to that. And first things first, blood pressure has to be taken properly. It's not right to have your blood pressure seated on an exam table with your feet dangling. You really should be seated in a chair with your back supported, feet on the ground, to get an accurate blood pressure. And also, we're looking towards blood pressures outside of the home. There are studies that suggest that, that's one point in time when a person comes to the doctor.
It's a snapshot.
What's going on? It's a snapshot. What is going on when they're not in the office? So great encouragement of ambulatory blood pressure monitoring.
Do you have any thoughts about that?
Yeah, I mean, if you look at the populations, where does the risk of heart attack and stroke start to go up? It's past 115 millimeters of mercury. And if you look at how you control, if you have a hypertension clinic, you get 80-90% control. But in Olmsted County, where Mayo is, we went out and found everybody in the community and pulled in a few thousand and checked their blood pressure, and our control was nowhere near because we weren't getting the people. We're only getting the people that come to us, not the ones in the community that haven't been treated.
Some have tried like a registry approach to enroll people with elevated blood pressure and to try to somehow follow up and make sure they're getting treatment. I don't know if that's something that you do in your setting or.
No, we do. We try to make that available to them, but there's no incentive for them. It's not like car insurance. You don't want to have a wreck because your rates go up. There's no incentive for the individual to control their pressure because we're a society, medical society, based on treating disease rather than we're paid to treat rather than paid to prevent right now.
So you think they should get some kind of an immediate incentive, a payoff or of some kind? I mean, is that something that people are trying?
Either that or start educate third graders on up how important it is to control your lifestyle throughout your life. Because to face it, if you wait till you're 55 and try to tell somebody to control their blood pressure and such, you miss 30, 40 years of disease-causing states.
One thing we could say is we are doing better. We have to reflect on the fact that we've changed the cut points for defining hypertension. We've been at 140 now for about 3 decades in this country. And we've gone from control rates less than 25%. And, as Tom mentioned at lunchtime, our best estimate now is a little over 50% for the population as a whole. We know in studies like trials where we are really monitoring things very carefully, we're giving the meds and so on, we can get that up to 80, 90%. We have several systems of care that are reporting 90% control rates. Now, that may be a little overestimated because there's some bias in the tools they use to report, but clearly they're doing better. And the things that are happening nowadays are really driving control rates up in this country, and it's using those systems of care, very active use of electronic systems, getting people other than physicians involved in the care of hypertensives. And we know that pharmacists and that nurses can be exceptionally good in this area. So there are a lot of positives going on, and we need to build on those and do better. And now the question is 140 where we should be? We just finished a trial a couple of months ago called SPRINT. And what that tends to show is in the high-risk hypertensives, when we got down to a target of 120, now a target of 120 means that if you're getting to that target, in general sense, 50% of people would be above, 50% would be below, and when you translate that to what we call a performance indicator in the clinic, that would be about 140, about 95% of people below 140. So we saw with that huge benefits, about a 30% reduction in all-cause mortality over just 3 years of treatment. In fact, the trial was stopped early because the cardiovascular benefits and the all-cause mortality benefits were so great. So
Paul,
I can see in this...
Could you tell us,
Sure.
in the SPRINT trial, how was somebody defined as being a high-risk hypertensive? So not only have hypertension, but also because since you were targeting the reductions for that group.
So these were older individuals. They weren't as old as me, but a lot of them were older. Well, in fact, most of them were. We selectively try to get a lot of seniors in there. So it had to be over the age of 60. They had to have high blood pressure. And these days, we don't take people off their meds to get an exact pressure. That would be unethical. So most of them came in. Presumably, they met the criteria at some earlier stage. And they had to have one additional indication of cardiovascular risk. So they were clearly high risk. They were a group that when we apply our risk modeling tools, we'd say a Framingham 10-year risk over 20% on average. So there's a high-risk group. And we just randomly assign them to either go to what is recommended on the guidelines now, less than 140, or to something lower than that, less than 120, really based on those observational studies where it looks like you've got a continuous increase in risk. And the results were really dramatic, and that study was stopped very early. So in this country, I suspect we are going to see guidelines coming out recommending going to lower pressures. Now, if you're in a low-income country where you're starting the process, I think for the juggler, you say, well, we're not going to be able to get everyone down less than 130 or 120, but we're going to start where the risk is highest and it's easier to capture people like where we were 20, 30 years ago. So I think for each part of the world, you have to customize what you're going to have as your goals and what you can really accomplish. But in this country, I think our goals have to be quite high because we are a country where we've got a huge problem from blood pressure, and we've got the resources and the systems to tackle it more effectively than we're doing now.
So I keep hearing from CDC about this thing called the Global Standardized Hypertension Treatment Project. And I don't know if you know about that.
So the Global Standardized Hypertension Treatment Project was piloted in Barbados. So that's the project I described. And it does touch on another area that I didn't mention, and that's the building and use of registries. So I've got a slide here, 43, if you can pull it up. And I think it shows an interesting approach, because here you have a team of healthcare providers all sitting at a desk, doctor, pharmacist, nurse, clerical staff. They all have different roles, and none of them actually knows what each other role is. The nurse thinks I'm doing the blood pressure, and that's the blood pressure the doctor is using. The doctor is ignoring the nurse's readings. The pharmacist just thinks that my role is just to give them the drugs, and there's no health information. And the clerk is like, well, I don't deal with health at all. I'm just here to make an appointment. And so they're all singing on a different page. And how do you get these people? And this, I know they look quite calm in the photograph, but they're quite argumentative, saying, well, my role is equally important. And not shown on this table, but even more important, is what's the patient's role? As I said to all of them, well, what do you think is the patient role in all of this? And they kind of look at each other like, to follow the instructions that's given. So how do you get the patient-centered approach? How do you use things such as home diaries, for instance, patients taking their monitor, and there's currently a drive in Barbados to have a home blood pressure monitor in every home, because we essentially almost have a home blood glucose monitor in every home. If you go to someone's house in Barbados for a meal, if you cough, they're going to check your blood glucose. And we want to be able to check your blood pressure and to record it and bring it to the doctor, and for that to be part of the conversation with the healthcare provider, so that we don't get a snapshot, so that we see trends and we adjust medication based on trends and not just snapshots. So that's one important, I think, legacy that the GSHDP has left, the use of home readings. And even other countries, neighboring countries, Trinidad and Jamaica, that were obsessed with taking blood pressure using the mercury device because it's the gold standard. I said to them, well, it might be the gold standard, and it might be more accurate, and that's debatable, but it's probably not an accurate reflection of what this person's normal blood pressure is if you're doing it in the office. And you could be over-treating them. And I say this to patients. I said, well, I'm really sorry you forgot your home readings today, because I can't make any changes, because if I do, I might be over-treating you, or I might be under-treating you. No patient likes to hear that. And so the next visit, they're coming with their home readings and say, well, look, here's what I got. What do you think about this dip here that I'm having in the evenings? Those kind of things are what we look for, and getting the patient more involved.
Steve, how do we motivate people to do the things that they need to do to prevent hypertension? I mean, we've been involved with, and I know everybody is working on various approaches to helping people quit smoking, or to stop the uptake of smoking. But frankly, some of these things, like how much sodium intake you have, I'm not sure that people are really fully aware of how much sodium they are ingesting.
Right. Two things. One is that as a community, I mean the whole country, we need to somehow protect those of us that don't understand what we should eat. And should we have foods that have large amounts of sodium in them? That's a very difficult question. People want to have their own choices, and that's very important. The other thing is I'm really impressed with is social media. I suggested to my wife that we, to lose weight, we get put our scale, hook it to Facebook, and every day it has. She didn't think that was a good idea for some reason, but I thought, if I would do that for me, I bet I would lose weight. In talking with the Fitbit guys this afternoon, earlier this session, it was really impressive what the data they see and how they see them when there's social networking that's kind of very friendly, not punitive, but actually very friendly with us to help educate us and motivate us.
I think what we see is increasing gaps, which is very distressing and difficult in a country like ours. So, for people like me who are older and who have resources, a higher socioeconomic status, I'm easily motivated. I cycle 25 miles in the morning. I'm very careful about my meals. And people, it's not just me. There are lots of people like me. On the other hand, at the other end of the scale, so our health is getting much better. At the other end of the scale, you've got people who don't have a wonderful, unfortunately, educational background. They're living day to day. They're oftentimes living in rural areas or in inner cities. and they have what we all refer to as a food desert. And so the choices are limited, and they're much more worried about day-to-day survival, and it's really hard to motivate. So a lot of people are working on it, but I think we have to reach out and do more, because it's easy for me to be motivated. It's easy for me to actually achieve some of those goals. It's much harder for other people in our population.
You're raising the issue of disparities, and I think we have here three people, the rural community, the urban community, the community in Barbados and really globally, where there are disparities. And how do you see this issue of the disparities and how we bridge past that?
It's really challenging now. A very interesting program that some people may be aware of is Lori Tisch Illumination Foundation sponsored a project called the Apple Pushers, because of food deserts in New York City. And there's a documentary online where you can went through the process of people who were immigrants obtaining permits to have push carts with fruits all over New York City in areas where there were food deserts. They didn't have fresh fruits and vegetables available in the local markets. And the interviews with the people who were first learning about eating fruits and vegetables, it was like they found a new thing. It was absolutely amazing. And really, a program to treat or prevent hypertension has to be culturally appropriate. And there are great disparities. If you look at the heart attack rate in women under the age of 50, it's highest in African American women. And the younger African American women have at least 3 risk factors for cardiovascular disease, 2 of which are diabetes and hypertension, and a third, obesity. And I think that we have to, the patient-centered care movement in our country is very important, because it leads us and care providers or community leaders in communities where there are people at risk can really be champions of helping us fight hypertension or preventing it in those areas.
I wonder if there are any questions from the audience. We have just a couple minutes. Yes.
Could you talk a little about the role of stress in fostering hypertension and the SES?
The role of stress and socioeconomic
So that's
issues.
really very interesting, because there was just a recent publication this week in Circulation, and in ischemic heart disease in women, and it actually is the first time it really included a part on stress. And in women, stress tends to increase heart rate and the heart's cardiac output, and stress in men tends to raise blood pressure. But stress does a lot of other things. People who are stressed can't follow a healthy lifestyle, tend to eat in response to the stress. They don't sleep well, and sleep increases circulating levels of cortisol and has been associated with increased blood pressure and belly fat. So stress itself is a multifactorial problem, but it does play into cardiovascular risk.
Yeah, I was going to say, I think stress is an important conversation for healthcare providers to have with their patients, because although all of us are stressed. I mean, we're stressed just being on this panel, but all of us are stressed. The end organs or the organs that are affected by hypertension, so the eyes, the brain, the heart, they can't tell whether that high blood pressure is because of stress or salt or what is causing it. And I think one barrier, certainly in my country, toward or even instituting care, starting patients on drugs, and lifestyle changes is this whole thing where the healthcare provider is like, oh, well, your blood pressure is 160, you're just stressed. Just relax some more, take the load off, and come back in 3 months. And maybe it's 155. Okay, well, chill out some more. So that's a major barrier. You have to be careful that that barrier doesn't kind of hinder starting care and instituting it.
Steve, did you have a...
Yeah, it is interesting that at night, is when we all rest, and our blood pressure needs to dip down. And if you have sleep apnea, as we just heard, that 50% of people with sleep apnea have high blood pressure, and 50% of people with high blood pressure have sleep apnea. But one thing that has been shown is to try to take that stress. I mean, I tend to ruminate at night about all the things I didn't do today and I have to do tomorrow. Yeah. And studies have shown if you will take be thankful for three things as you go to sleep. It increases your optimism, decreases your stress, and decreases your heart attack rate. I'm not sure about blood pressure, but I do know it reduces events.
Well, I don't think stress is good. Nobody wants stress. We are against it. Mm-hmm. Having said that, when we look at stress reduction interventions, a lot of bad trials, we can't make sense out of them. They're hard to interpret.
Hard to do.
When we've done, you're worried that their methods are just so bad that you can't make any sense of them. When we've done big trials funded by the NIH, maybe we just don't know how to reduce stress. But with the approaches that we've used, they have not been effective in lowering blood pressure. And that's not, I'm not saying that to recommend stress. I'm saying it, and I think the things Steve talked about, like weight loss, physical activity, reducing sodium, increasing potassium, moderation in alcohol consumption, those are very well proved. So I'm against stress, but if you want to lower blood pressure, we have to go with the things that are very well proven to be effective in prevention and in treatment. And they, to this point, haven't included in high-quality studies stress reduction techniques.
Michael Clegg, I know you've done a lot of work in this area. If you have anything, to add to the discussion.
I think it's been a great panel, and I have lots of questions. But let me just start with
you have all the answers, Mike.
Paul, I agree totally that if you look at the stress trials, TOPE and others, there's no effect in those trials, except if you look at small trials of transcendental meditation, there's a hint of an effect. And I'm just wondering why, and you're right, we need to use evidence. We can't be recommending things. A quarter of the world's population has hypertension. It has to be evidence-based. I'm just wondering why there hasn't been more trials of TM in high blood pressure, because all the other stress management techniques don't work.
Yeah. The other area that I've always thought was very interesting, and sadly Tom Pickering died, who was the major advocate, was the whole issue of job stress. And some of us, like Lynn and Mike, very stressful jobs, but you can control your environment. Other people have jobs that we don't think are so stressful, but as we've seen really back in the 1950s, people like bus drivers, they have very stressful jobs because they can't control the stress environment.
Or Dilbert, right?
Yeah.
Gil Oman has had his hand up.
Just a quickie. I think this word hypertension is part of our problem. If we spoke clearly about high blood pressure, people would understand. I had a guy who did a PhD in anthropology years ago, Dan Blumhagen, and documented that many people stop taking their medications and go off their diets when they feel their stress has been ameliorated.
They're not tense anymore.
In any case, they don't understand this as hypertension.
Yeah.
Technically, it has to do with a sphygmomanometer, which of course is totally obscure, especially these days. And I wonder if anybody's given any thought to trying to direct and practical with the condition we're describing.
Yeah, I think the nomenclature is absolutely important. I once had a patient who said to me, why are you calling it hypertension and not just high blood pressure? Because that's really what it is. And I'd be a lot more concerned about high blood pressure than just hypertension, because that's your term. So it's even just changing the terminology that makes a huge difference. But also getting patients to realize that we can't switch off stress in our life. Stress is going to be there. As soon as we leave the office, as soon as we enter the office, we're stressed. And we need to institute a lifestyle change and adherence to various medication protocols to lower blood pressure. Because you're right, we don't have convincing evidence to suggest that stress elimination really does have a significant role.
And I would go a step further in not only changing the nomenclature, but also explaining to the person who has high blood pressure that they will always have high blood pressure. Because oftentimes people stop their medicines when their blood pressure is better. And also or their life situation changes. Or a project that we now have at NYU where patients can now enter in changes to their medical history onto their medical record, and it increases their engagement. Commonly, they ask to have hypertension removed because their blood pressure is better.
Yeah.
That's so interesting. We're almost out of time. I'm wondering, the two of you, any...
One other thing, maybe I call on Mike. I think we have to sort of step back and say, why is it that one person gets a complication of high blood pressure and the other doesn't? Why does one person get a stroke? Why does one person get kidney disease? Mike did the earliest study looking at the relationship of blood pressure and kidney disease and showed that in African Americans it was enormously higher than in whites. And that I think we haven't come to address
Paul,
yet.
You know far more about hypertension than I do, high blood pressure, sorry. But we treat it not so much to lower the blood pressure, that's an intermediate step. What we're trying to do is prevent cardiovascular disease, morbidity, mortality. And so I think when you see patients, one of the things I used to do is show them a plot of the Framingham risk by blood pressure. And for somebody who didn't smoke, and then you see what the level of blood pressure, and then add on a smoke or add on obesity. So one of the things we have to do is use a multifactorial approach, just what Steve was saying, that if you really want to reduce risk, it's not only blood pressure reduction, it's these other factors as well in practice. I think, we know that if you look at blood pressure, that populations that have high cholesterol tend to get large artery disease. So if they have hypertension, they tend to get coronary artery disease. Populations like Asian populations that have high blood pressure but low cholesterol, they get small vessel disease. They tend to get small vessel stroke. They get kidney disease.
Well, I think it's time, unfortunately, to bring this session to a close. Please thank our speakers for a very wonderful discussion.
Thank you.